Hi, everyone. Welcome to the open forum discussion on oral cancer, its treatments and side effects webinar presented by the Head and Neck Cancer Alliance and American Head and Neck Society. I'm Orly Coblens, Associate Professor of Otolaryngology and Head and Neck Surgery at the University of Texas Medical Branch. I want to thank our panelists for joining us today to share their feedback and answer some questions from the webinar audience in areas of head and neck oncology, oral medicine, and speech and language therapy. To begin, I'd like to introduce each panel member. We have from our ambassador survivor, Jamie Powell, who's going to share her really powerful story. At the age of 37 and a mother of 2 young boys, Jamie was diagnosed with tongue cancer. She underwent surgery with removal of half of her tongue and the lymph nodes from her neck. A month following surgery, Jamie learned that the cancer had infiltrated her nerves and radiation was required. During radiation, she experienced excruciating mouth sores, loss of sense of taste, and severe burns. All of her treatments were during the height of COVID-19, so she faced her treatments alone. Jamie has slowly overcome many of the treatment side effects and is back enjoying her life with her growing boys. I'd like to give Jamie a few moments to please share her experience with all of us. Please feel free throughout the webinar to put in questions either in the chat section or in the Q&A box. Thanks, Jamie.
Thank you. Hi, everyone. I'm really excited to be here and share a little bit about how life has been since surgery back in March of 2020. Good old March 2020, really great time. I had my surgery. I was diagnosed with tongue cancer. It was March 5th, 2020, and I had my surgery on the 23rd. By myself. Of course, we all know lockdown was going on. So I was in the hospital for about 10 days and then they sent me home. So I was able to be with my family. They taught my husband how to do the feeding tube and all the bandage changing, all that, all through FaceTime. So it was just really weird, but we got through it. And I want to talk more about how I was with radiation, because I felt like that was really the hardest part of my treatment. I had 30 rounds of radiation to the head and neck. And during radiation, it was the second week, I was told that my symptoms or side effects would probably start hitting by like week 3 or the second week. By the end of I think it was day 10, it was just full blown, like my neck was completely red. I actually started to blister, so they gave me some burn cream to start putting on. But everything from my blisters all in my mouth started happening around day 9 and 10. And everything, I remember trying to drink water and it just tasted like sewage. And it was just, I thought I was over the worst from surgery, but radiation was definitely more difficult. So as radiation went on, I continued to get the blisters. I lost I couldn't speak. So all that hard work from learning how to talk again, I lost that. So when radiation was finally over, I was able to start speech therapy again, along with OT, because I couldn't lift my arm over my head. I didn't realize that from the neck dissection that I would have issues with my arm. So after coming out of, ringing the bell and being done with radiation, I thought, okay, now everything's going to get better. It's going to be fine, smooth sailing, but it just, it got harder. That first 2 weeks after radiation, it was really difficult. It was hard to adjust to life after seeing your doctors every day. Now you're kind of just pushed out on your own, and they're kind of, that was comforting to know that someone was watching you every day, but now you're not. So it was kind of the mental capacity of it too. Like I was now realizing everything that I had been through for the last 9 months. And it was difficult, but I had really great speech therapists. And every day I had a little book that I would open up and I would sit and I would mark down my exercises I would do. And I just was very strict about it. I had my routine. My kids were very young, 2 and 4 at the time. So I felt like, you know how you talk to children, you have to, in a very sing-songy and very slow and articulate. I felt like that helped a lot with my speech. So in a way, I felt that was part of my speech therapy, having young kids. And I had all the routines that I needed to start getting my voice back, and I began getting confident, but I do struggle still with food. And at the end of the day, around 4 o'clock, I start to get fatigued. It's just interesting now how my quality of life has changed, but it's just different in a way that now I know new tricks and tips on how to manage it. But I am very lucky and I'm very grateful to be here to share my story and maybe help somebody who's going through it right now and might need some tips or have any questions about certain exercises that benefited me that they may not know about yet. So that's a little bit of my story, and I'm here to answer any questions that I can, along with everybody here who is far more knowledgeable about it than I am. But thank you again for listening, and yeah, just happy to be here.
Jamie, thank you so much for sharing your story. We look forward to hearing your expert opinion as well. You definitely know what this is like firsthand, and we really appreciate you be willing to share your experience with everybody. I'm going to introduce our medical experts and give them a moment to introduce themselves. First, we have Paulie McMillan. She's the co-director of the Trismus Clinic and pre-doctoral clinical research fellow at MD Anderson Cancer Center.
Hello, everyone. Thank you, Jamie, for sharing your story with us. And thank you to the Head and Neck Cancer Alliance for inviting me to be on this panel today. So again, yes, my name is Paulie McMillan. I am a senior speech language pathologist and co-director of a specialty clinic here at MD Anderson called the Trismus Clinic, where we are dedicated to helping patients open their mouths. We see patients at all time points. So at diagnosis, we can see them all the way through their active treatment and years into survivorship, arguably as long as they need us. So we are with patients throughout their continuum of care. I'm also heavily involved in the research lab with Dr. Kate Hutchison. So thank you for having me today.
Awesome. Thank you, Holly. We also have Dr. Michael Toth, who is the assistant professor in head and neck and surgical oncology, microvascular reconstruction in the Department of Otolaryngology at Vanderbilt University Medical Center.
Hello, everyone. Michael Topf here. I'm a head and neck cancer surgeon and reconstructive surgeon at Vanderbilt, Nashville, Tennessee. Perform surgeries on the head and neck, perform many of the surgeries that some of the survivors are sharing in the webinar chat, which I just think is so cool that so many attendees are sharing their where they're from and their stories in the chat. Reconstructive surgery as well, anything from a skin graft, perhaps similar to what Jamie underwent, to local tissue transfer, to free tissue transfer of arm tissue or leg tissue to the head and neck. And would like to thank the American Head and Neck Society and the Head and Neck Cancer Alliance for the opportunity to be here tonight. And a friendly reminder, we do have a Q&A aspect to the panel as well. Feel free to ask questions for the panelists there. Perhaps a better place for questions than the webinar chat.
Awesome. Thank you, Dr. Toth. And I have Dr. Alessandro Villa. He is the Chief of Oral Medicine, Oncology, and Dentistry at Miami Cancer Institute. He also serves as a professor at the Herbert Wertheim College of Medicine, Florida International University.
Hi, everyone. Good evening and good morning. I see that we have some participants also from Australia, which is very exciting. Alessandro Villa here. I'm the Chief of Oral Medicine and Oral Oncology at Miami Cancer Institute. There's very few of us, at least in the United States, and as oral medicine specialists, we work closely with patients with head and neck cancers to treat and minimize some of the mouth problems that can occur during and after treatment, some of which Jamie was sharing with us earlier today, like mouth sores and dry mouth. And the goal is really to accompany patients during their cancer journey to make sure that their mouth remains healthy and comfortable throughout the treatment and also beyond. Very excited to be here, and thank you again for having me, and thank you to the Head and Neck Cancer Alliance for this webinar.
Awesome. So now we want to make sure that we get lots of questions from the audience. I see some questions are already coming in. I'd like to start by asking the panel one set of questions that what are some of the most common complications that you see from head and neck cancer therapy? I'll start with Dr. Villa on that one.
Yeah, thanks for the questions. As you all know, cancer treatment can cause mouth and throat problems, and most of these complications in patients with head and neck cancer are caused by either chemotherapy or radiation or a combination of both. And we typically classify these mouth complications into acute or short-term and long-lasting. And when we look at the oral complications, the mouth complication from head and neck cancer therapy, these can include oral mucositis, which is characterized by the presence of very painful mouth sores. That's what Jamie was describing earlier today. Luckily, these tend to resolve in most patients after completion of either chemo or radiation therapy. But during cancer therapy, patients may also develop secondary infections in the mouth. One of them is a fungal infection called candidiasis, also commonly known as thrush. Dry mouth, I see that some of the members today are already describing it as one of the side effects that they are experiencing. This is very common, especially in patients receiving radiation therapy. Along with dry mouth, patients may develop also taste changes. Food may taste differently or not tasting the same anymore. Pain in the mouth, and later on, patients are also at higher risk of developing what we call Osteoradion necrosis, which is the breakdown of the bone in the areas of the jaws that receive radiations. So all of these complications, unfortunately, are common and negatively affect the patient's quality of life, and can also lead to other problems like dehydration or malnutrition, and in certain cases also hospitalizations.
Awesome. Does anybody else want to add to that, or should we move on to some of our Q&As that are coming in? And to the Q&As, I see one quick question that came in through the chat. Is there any particular mouth guard that you'd recommend to help prevent any cracking of teeth, or any prevention to do for dental hygiene purposes?
Yeah, the dry mouth is a very significant problem that can cause dental cavities, and teeth can also break because of this. So it's really important to see the dentist before starting therapy and after therapy, and make sure that everyone is using a prescription fluoride toothpaste to minimize the risk of developing these caries. In terms of wearing a night guard or not, it really depends if patients are clenching at night. Other than that, there's no real studies that can show that wearing a night guard can minimize the breaking of the teeth, especially in the context of dryness or because of cavities. In some cases, your dentist may fabricate a soft tray for the delivery of fluoride gel, especially at nighttime before going to bed. That's not really a night guard, but it's mostly to cover the teeth and make sure that the gel with fluoride can protect the teeth and have a lasting effect.
Awesome. Anybody else have any comments on that one, or I can move on to a different question? All right. There's one question about how long, Jamie, did it take your sense of taste to improve?
So I lost my sense of taste very early on. I finished radiation June 30th of 2020, and I did not taste, my taste did not come back until October, and it was coffee, and I cried because I could taste it, and it was what I remembered coffee tasting like. And coffee's the only thing that tastes similar to what I remember. Everything else tastes slightly off. It doesn't taste the same way. Like I can't eat any beef. It just tastes too much like it's like that mineral, like copper, like blood. But it just takes time. The best thing is, don't be so hard on yourself. The healing process is a lot longer than what you're told, maybe, because it's different for everybody. They might say, oh, it could take 2 weeks or 3 weeks, but mine took months, but it did come back. And I followed all instructions, and I was very type A about my routine, and it happened. So it just takes time, and you have to along with the fluoride toothpaste in the question before, during radiation, I couldn't even open my mouth wide enough after treatment to get a toothbrush in. So I have gauze that I would use children's toothpaste to just get something in there, because I was like, God, I can't not brush my teeth for a month. It was really, really hard, but just doing that, just tiny, gave me a peace of mind, and hopefully it helped. But it's hard finding toothpaste right now that's not burning my mouth. I have to use very mild mint. And I think the one I'm using right now doesn't even have that.
Awesome. Thank you. Well, I hope it continues to get better for you. Paulie, I see there's a question about trismus and heat for stretching. I'd like to make sure everybody's on the same page with the definition of trismus. Trismus is difficulty opening your mouth, which a lot of patients have after extensive treatment with head and neck cancer. So Holly is definitely an expert on this. Holly, what's your thoughts?
Yeah, I'm really grateful to Bill for bringing this up. This is a question we receive quite often. And the answer, I fear, for a lot of my responses today are going to be, it depends. Heat can be exceptionally helpful. However, if you've had radiation, we have seen some terrible tragedies where patients fall asleep with a heating pad on, and sometimes the sensation is not as good, and then they end up with some really terrible burns. Heat is also not wildly recommended if you have lymphedema. So there's a lot of factors that can contribute. It can be great for muscle recovery and relaxation, but it may not always be best given your situation. So what I'd say is make sure you're evaluated by your team, and they can help direct you, whether it's heat, ice, neither, stretching, or maybe some different modalities. But heat can be helpful in the right setting.
Awesome. Thank you. Have you noticed anything that people can do to help prevent trismus from the onset of diagnosis?
Yeah, it's really interesting. The data is somewhat mixed in this realm, and I'd like to hear Dr. Toph's opinion on this as well. There isn't strong data to suggest that prophylactic or preventative treatment, if you start working on this before it becomes an issue, that we can really prevent it. It seems to be the most meaningful treatments are coming once you see that your mouth opening becomes a little more difficult. So again, it's mixed in there. What I would say is movement is medicine, particularly when it's pain-free. So we encourage people to keep moving that mouth through speech, through swallowing, active activities of daily living, and then as well as your stretching routine. So as soon as you're noticing an issue, definitely say something to your primary team so that we can get you moving in the right direction.
I agree with Holly. I've been impressed by patients that take kind of an active role in their therapy and do exercises with their speech language pathologists and at home. I think there can be an improvement in trismus. Obviously, avoiding it up front is the best treatment, but if trismus does sink in, there are options, and encourage you to reach out to your local speech language pathologist. And I'll also just say, Dr. Villa, there are a lot of questions, dental related questions in the Q&A. If you want to take a look, I think you're the most qualified to answer.
I'm trying to respond to them. Yeah, thank you.
Awesome. If there are any ones that you want to address live, let me know. I'm happy to share them. There is a question about if it's okay, just a follow-up one for you, Holly, about if it's okay to use ice if somebody has lymphedema.
So lymphedema is a physiologic failure of your lymphatic system, meaning the vessels are not moving the fluid, we don't have nodes available, or the nodes are damaged. So ice is really nice when it comes to other types of inflammation or swelling, but it's not particularly effective for lymphedema when it's a transport issue. If there's pain, again, I highly encourage you to work with your teams. They can point you in the right direction if ice would be beneficial, but we run into the same issue sometimes because of surgery or radiation. If the sensation is not very good and you leave that ice pack on too long, we can run into some real trouble. So again, I point you to your teams for that, but it can be helpful from a pain management standpoint, less for lymphedema.
Awesome. Jamie, what does your daily exercise look like to help sort of, what does your daily routine look like to help prevent trismus and do exercises on your shoulder and your mouth?
Okay, so I'm going to demonstrate. Unfortunately, I have it very, very bad because every morning I wake up at 4:30 a.m. and I have to physically use my hands to pry open my mouth during the night. Well, I sleep at an angle. I mean, I think a lot of us in here know we can't sleep flat anymore because of the dry mouth, and I have no salivary glands, so everything is just thick mucus, and it's so gross, and it's just it's the worst. So I sleep sitting up, and everything, I don't know what I do at night, but everything gets hard, and in the morning I'm like the Tin Man. I have to like get up and oil my mouth. So I just start like that, and then I take a spoon like this, and while I'm like doing my makeup or getting the kids ready for school, I'm just like, even that's painful, but I just do that 3 times, 30 seconds, or sometimes I just leave it in there and it starts to gradually start making it less tight. It's just like exercising a muscle. I mean, I did ballet for years, so I always use the analogy of like it's the rubber band and you just want to keep stretching it until it gets a little bit more elasticity. But unfortunately for me, it'll go back to square one at the beginning every morning. So I wake up, it's like Groundhog's Day for me. I get up, I do the same thing, and I restart. But I found something that works for me, and it's manageable. And I also do the swallowing it's like you're swallowing a golf ball where you hold it up at the top and then swallow. I do that 3 times, 3 sets, 10 times. And then I do that. I can't move my tongue side to side. I try and do that. Like I don't have any mobility to stick my tongue out, but I get it going. So then like, it's kind of by thinking it to prepare myself for speaking for the day, because yeah, it's just getting it revved up and I have more confidence and that I won't sound too slurry or the mucus won't get in the way. It's a weird thing that now we have to find things that work for us. So that's what I do. I just keep this. You don't need a Therabite or anything. You do this, or you can stack tongue depressors.
Yeah, I definitely tell my patients the tongue depressor stacking thing. So yeah, but consistency is a great thing. Dr. Toth, if I'm worried that I have another pain or lesion in my mouth, when should I see my doctor?
I would go see your doctor as soon as you can. I don't think you need to go to the emergency room, but if one of my patients messages me with new symptoms, I try to get them in, within a week or two. We take, as medical providers, we take any new signs or symptoms very seriously in a head and neck cancer survivor. So I encourage you to reach out to your doctor.
Awesome. Thank you. Let's see. Is there any known research or treatment going on for long-term survivors of radiation damage? Holly, I think this is probably right up your alley.
Of course, there's a ton of research going on at different institutions. I will actually post a link in the chat for some resources to take a look around the country, around the globe, maybe at some of the trials that are happening now.
Awesome. There's a lot of questions I see, Dr. Villa, for you about types of toothpastes and things like that. Do you want to address what your recommended
Yeah, I
dental care regimen is for our survivors here?
Yeah, absolutely. One of the challenges with some of these prescription fluoride toothpaste that some of you raised is that they have a mint flavor, which can be bothersome, especially in patients with dry mouth or mouth sores. MI paste, M as in Mary, I paste as different other options with both phosphates and fluoride that can help protect your teeth. They have several different flavors that are more gentle than mint, and some of my patients actually really like them. So that could be another option. It's available even on Amazon, so it's relatively easy to get. Prevident, Gelcam, to name a few of others, prescription fluoride toothpaste. Most of them have mint. Biotin is another product that can be helpful in patients with dry mouth. And in terms of what can be done to minimize some of these mouth complications, it's really important to find and treat oral problems before cancer treatment begins, as I was saying earlier. And this can really prevent some of the complications or make them less severe as you undergo treatment. And the prevention of mouth complications include good oral care, good oral hygiene, and regular dental checkups. Again, before treatment begins, but also after treatment is completed. And if there are problems such as cavities or broken teeth or loose crowns or fillings and gum disease, these can all get worse or cause other issues after cancer treatment. So if there are any dental problems, these should be treated before cancer treatment begins. And by doing so, you can minimize a lot of these mouth complications. So I think it's really important that dentists are part of the cancer care team. It's important to choose a dentist who has also experience in treating patients with mouth complications of cancer therapy. As oral medicine specialists, this is what we do. We follow patients with mouth complications during and after cancer therapy. And these will also avoid, if you see a dentist before cancer therapy started, it will also help avoid the need of further dental treatment during cancer therapy or after cancer therapy as completed.
Thank you. Dr. Toth, there's a question about what impact does radiation have on the thyroid in short term and long term? And how
That's
should
a good question. Yeah, that's a great question. So the radiation therapy, surgery, and chemotherapy can all cause disorders of the thyroid gland. We do see not infrequently hypothyroidism, meaning that the thyroid gland, despite being there, does not function properly and make enough thyroid hormone. And I typically check thyroid hormone levels on my head and neck cancer survivors every 6 months. That can be done by your, surgeon, your medical oncologist, your radiation oncologist. It also can be done by your primary care doctor. But if you have a history of radiation to the head and neck, in my opinion, I'd get your thyroid labs checked every 6 months. If you are hypothyroid, you can take thyroid hormone replacement. It's a pill every day, and it works relatively well.
Yeah, some of the symptoms that I've seen patients have is fatigue or weight gain. It's kind of unexplained. So if you have some of those symptoms, be sure to reach out sooner than that every 6 months or yearly test that you do. Jamie, are you seeing any questions across the chat that you want to address?
I think that I talked about the taste, how eating. I still cannot. I can't do anything. I can't even do ketchup. My eating is it's not fun. It's I always do a protein shake in the morning, and that's how I know I get all of my nutrients. And then I still do soft foods. Like I love quesadillas and like pasta. But if I'm planning to like go out to dinner or meet up with friends, I make sure like I look at the menu before and can find something that I can eat, because I can't chew like, sorry, my dog can't chew like tough meat like chicken. It's more of the fatigue of chewing.
Yeah, absolutely. Do anybody in our panelists have any recommendations for the management of either thick secretions or thick phlegm and saliva? There's been a couple of questions across the board on that one. Perhaps Dr. Toth?
Yeah, so for excessive saliva, I've put a few responses in the chat. I've had some pretty good success with Botox injection to the parotid glands and submandibular glands. I'm always amazed at how well that can work for patients. Oftentimes it requires repeat injection every 3 to 6 months, but sometimes we can get the glands to kind of burn out and get long-standing effect. And that is typically covered by medical insurance. Thicker secretions, are a challenge. If I can get the insurance company to do hypertonic saline nebulizer treatments, I find that can help. You can also make sure you have good humidification in your home, and pick up an extra humidifier or two. Interested in hearing the other panelists' response as well, though, for that.
Yeah, I can add a little bit to it. There's also a few studies that shows that pineapple juice can be helpful, believe it or not, because it has a lytic agent, so it can kind of moisturizes a little bit more the mouth and kind of dilute those dry secretions. There are also some mucolytic drugs available. These are usually used in patients with other conditions that also develop dry secretions, but it can also be helpful in patients with secretion from radiation therapy or cancer treatment for head and neck cancers, like carbocysteine is one of them. So I agree with Dr. Toth. They're challenging sometimes to treat and manage, but there are some remedies that can help you kind of minimize the effect of dry secretions in the mouth.
And we also use, it's not so much for dry mouth, but really the thick ropey, the diet flat ginger ale. We do diet to keep our dentists happy. But the sugar, you're welcome. The sugar is helpful, but a lot of patients find that it thins it out, and it makes it easier to either spit out your thick ropey secretions or to swallow them down.
Awesome.
Apple juice and diet flat ginger ale. I'm learning something at this panel as well.
Me too. That's exciting. I'm ready to try it. People also have concerns about being less interested in eating than before, and being able to sort of motivate themselves to continue to eat. I know there are some stimulants that you can give, but does anybody else have any recommendations? Jamie, I'm sure you've gone through this too.
Yeah. So I got to a point after, or I think this was during radiation, I couldn't even be around my family when they were eating because I was so hungry. You're just so hungry, and food doesn't bring you joy. It's just, I was having a difficult time being around my family when they were eating for meal times. And as a mom of 2 kids, like I have to be around them when they eat. So I talked to a therapist about like why my feelings with that. I was like, dude, this is weird. Like I can't watch them eat. Like I'm so hungry. I'm jealous of them that they can just eat without thinking about it. And it was really hard for me, but I talked to somebody and we worked through it. And now it got to the point where cooking dinner for them, I like I said, I like the routine. So I get all those HelloFresh meals for my family. I don't have to worry about what I'm going to make. Everything's already there. I just make it for them. And then I have like my little spot for dinner too. But it was like little things I could find to help make the food process less of a hassle. But it does get better. So I would gradually start. I'm like, hey, I I think my mouth feels good. I'm going to try this. So I would try like something with like chicken with like ranch with it. And I was like, okay, it's a minor burn, still burns, but it's improvement. So it's just you know, if you're having a good mouth day, like you just try it, you know, it's trial and error. And some days it's good. And some days you'll have 3 bad days for that one good day. It's just the way that it is now. And we get used to it, but the quality of life is definitely different. We just can't be like, oh, have a snack on the go. Like, oh my God, never again will I be able to just like, oh, Cheez-Its, I miss Cheez-Its so much, but it's probably better for me.
Anyone else from our panel? Dr. Toth, what do you do for patients that have a lack of desire to eat?
It's challenging because, you know, taste and smell is just so important to eating. I struggle with it with those patients. I'm fortunate in that I work with a medical oncologist, Dr. Barbara Murphy. She's very involved in the Head and Neck Cancer Alliance, and to be honest with you, she often helps me with that patient population that is suffering from kind of loss of interest in eating and drinking, and I'm thankful to have her as a partner.
Awesome. All right, there's another question here. Jamie, you demonstrate such a lovely and positive energy. How have you been able to mentally cope with these huge physical changes? And I agree.
I have my bad days, you guys, really. You know, I put everything out there on social media, like during 2020, like we were just talking to like our phones, right? A lot of us got on Instagram or TikTok, and I was just documenting, sharing how I felt that day and little things that, you know, I use a lot of humor to get me through. And sometimes my humor, not everybody thinks I'm funny, but it was little things that helped me get through. And that's how I had people messaging me like, hey, this is happening to me, this is happening. And I had no idea because I thought tongue cancer was this rare thing because I couldn't find anybody out there when I was diagnosed. So I kind of made this community that we could all, there were someone who was like me and we could all talk to each other. So it was, I finally felt confident, and I started to have better days from my confidence, knowing that I wasn't the only one out there going through this, and that I had somebody else that I could bounce questions off of that was someone around my age and was going through it too. So that was very helpful in gaining my confidence and, you know, having more good days than bad days.
Awesome. I'm glad you're having more good days than bad days. That's important. There's a couple questions that I'd like to ask our panelists about prevention of osteoradion necrosis or treatment of osteoradion necrosis. That's basically a damage to the jawbone or bones within the facial structure most commonly after radiation. Sometimes they can require additional surgery, even major surgery that's as big as the surgery that you had for your primary cancer treatment. Maybe I'll start with Dr. Villa on that one. I think you've been answering a bunch of questions, but it seems that there's a lot of people interested.
Yeah, of course. In terms of minimizing the risk of osteoradion necrosis, as I was mentioning earlier, it's really important to see the dentist before starting radiation therapy to make sure that all the cavities are filled, and if there are teeth that needs to be extracted, that they are extracted a few weeks before starting radiation therapy. This again minimizes the risk of developing this complication following radiation therapy. There are, in terms of management, and feel free to jump in, there are different options that also depend on the severity of this complication. There is one of the protocols that are used for some of the cases is called the PENTO CLO protocol. Here in the US, we don't have one of the medications in the protocol, but it's a combination of a drug called pentoxifylline and vitamin E taken on a daily basis. These can help treating some of these complications or reduce the risk that one case of osteoradion necrosis gets worse over time. Some patients may also require antibiotic therapy in some cases for a long period of time, especially when there are recurring infections in the bone. And when the cases are more severe, also surgery is recommended. And this is something that maybe you, Dr. Toth, can talk about, or also Dr. Coblens.
Sure. Yeah. Osteoradion necrosis is a challenging problem after radiation therapy for head and neck cancer. I have had some success with the Pentaclo protocol, both with improving patient symptoms as well as stopping the osteoradion necrosis from progressing. We do have to sometimes do jawbone reconstructions for osteoradion necrosis, which can include tissue transfer of fibula bone or scapula bone or radius bone to the jaw to reconstruct. I'll also say there's some exciting research coming from the Cleveland Clinic and a Dr. Michael Fritz about early free tissue transfer to prevent osteoradion necrosis. And that's kind of a developing field, but I've been really impressed by some of the research that the Cleveland Clinic team has been conducting on rescuing jawbones that are starting to have osteoradion necrosis. I don't know if Dr. Coblens has anything else she'd like to add.
No, I use the Pentaclo regimen a lot for my patients with early exposure. I know there's some places out there that still do hyperbaric therapy. I don't personally recommend that for my patients. There are some people that do hyperbaric oxygen prior to dental extractions. Dr. Villa, maybe you've got some insight into that. I'm also excited to see what the Cleveland Clinic is coming out with. I saw that paper too. It's pretty exciting to see to help prevent it, but it's a pretty big dedication for prevention. So I try as hard as I can to be as conservative as possible with patients that get osteoradion necrosis. Because I like to save anything major for when there's serious complications that occur, like a fracture.
Yeah, you mentioned HBO therapy, and there was also a question in the Q&A. HBO, there are some studies that show that may prevent or minimize the risk of osteoradion necrosis in patients that receive radiation therapy and require adenal extraction. The protocol is 30 dives before the extraction and 10 after. Actually, most of the studies are coming from the Miami area, from one oral surgeon that used to work at the University of Miami. However, when we look at the studies, the response is really 50-50. So it's really controversial. It may be helpful for some cases and for the regeneration of the gums around the area where the tooth was extracted, but it's generally not recommended. We're actually part of a study group now looking specifically at treatment options for HBO. So there's some exciting new guidelines that will come out soon.
That's great. Awesome. Thank you for sharing that. Holly, you've got some feedback?
Yeah, I want to follow up one more item about the osteoradion necrosis before we move on. It can be exceptionally challenging to rehabilitate as well. So I just want to encourage any of you, if you are doing your mouth opening stretches and you feel sudden pain or an onset of pain, or there's something changing with the sensation, please make sure you reach out to your dental, your head and neck surgeon, your oral oncology teams, because it can be, we see patients in our clinic, that mouth opening clinic all the time, where they have pain or maybe they don't. We assess for ORN of the mandible, and we're the ones to find a fracture, or we find the ORN, and it's not safe just to crank and just to stretch. It really needs some different medical management. So please, if you're having pain or you have concerns, reach out to your teams.
Absolutely. Dr. Toth, there's a question that I think you want to answer live about post-radiation risk of stroke. And there's also been some ones about sort of carotid complications from radiation. I know you're not a radiation oncologist, but perhaps you can share with the webinar what your thoughts are.
So that's another side effect of radiation therapy, is that it can cause thickening of the carotid artery and progression of atherosclerosis. I'm not sure that head and neck cancer survivors are any more significantly at risk of stroke, but up to 10 to 15% of patients with radiation to the neck can develop carotid artery stenosis. And it's very reasonable, if you have a history of radiation, to get a carotid ultrasound. It's an ultrasound of your neck to check the blood through those arteries. If there is a stenosis, then that could be operated on by a vascular surgeon. I think it'd be important to make sure that the ENT surgeon that is taking care of you is aware that you may undergo a neck procedure. I think that you could potentially prevent atherosclerosis by quitting smoking if you're smoking, and also just kind of eating a healthy and balanced diet. It's a really good question, and probably an underreported late effect of radiation therapy to the head and neck. So thank you for the question.
Absolutely. Some other questions that are coming across is about some nerve side effects from surgery, including numbness around skin incisions, numbness of the ear. I can kind of address a little bit of that, and I'll ask Dr. Topf to also give his. I think it, as Holly mentioned, a common answer is it depends. It depends on what kind of surgery you had. It depends on how extensive things were done. It depends on if nerves were sacrificed or not. Generally, it also depends on patient physiology and healing powers, some of which we can't really explain. Numbness around incisions can take weeks to months to even years to really get full sensation back, and sometimes that never really happens. But usually it narrows down to something that's a little bit more tolerable over time. Dr. Toft, do you have any thoughts on that?
I agree. It can sometimes take months. For mal patients in particular, they need to be really careful shaving after neck surgery and incisions. I do see improvement, usually starting at about 3 months after surgery up to about a year. Usually at a year, kind of what you have in terms of numbness is what you're going to get. But we definitely see improvement up to a year for sure.
Holly, what are some of I see a lot of questions coming in about some exercises again. What are some of the most common exercises that you recommend to your head and neck patients? There's specifically a question was about maxillectomy, but I think it's important to kind of address it. I've seen it for a couple of people coming across the Q&A.
Yeah, so I'll start with the mouth opening, the trismus questions. Following suit, it depends. So we've started working on algorithms in our clinic. There are several different devices on the market that can be very effective, but we're finding that soft tissue matters, and it really tells the story. And it can be if you have swelling versus if you have scar tissue versus if you have the late effects from radiation where your skin and your muscles may feel a little bit scarred down from fibrosis. And depending on the scar tissue, you can use, like Jamie mentioned earlier, the stacked tongue blades or a spoon turned sideways, or a TheraBite or an Aura Stretch. There's a lot on the market that's out there right now. Dynasplint, I think, is still around, as well as custom devices. So again, it depends on the soft tissue. And that's, again, I feel like I keep saying the same thing, but check with your providers so they can help you make those decisions and make sure your teeth and your bones are in good health before you start. The other are also speech and swallowing exercises. Jamie did mention some of those earlier as well, and I'm happy to post in the chat a link to some of the publications that highlight those exercises.
Awesome. What about does fibrosis improve over time? It's kind of a challenging one and also one that starts with it depends, but
I have a feeling everybody on this panel is going to have some good insight there. It also depends on what you mean by improve. So can we improve range of motion? Yes, usually we can. We're actually, there's a paper that will be coming out soon from our group, particularly looking at radiation and movement. But yes, we can see some change in neck range of motion and jaw range of motion. So if you mean improvement by that, yes, we sure can. In terms of tissue integrity, that's a bit more challenging. Usually fibrosis is progressive. The longer you get out from your treatment, the more it may become apparent. I'm also interested to hear from Dr. Villa and Dr. Toth, if you guys have seen some of the changes with the pentoxifylline and vitamin E. Anecdotally, in clinic, I have. It's been quite tremendous. I've had some patients come back, after 12 or 18 months of use, and there is a palpable change. Again, not for everyone, but we have seen some nice improvement in tissue integrity for some folks.
Yeah, I've used Pentaclo protocol for ulcers after radiation with positive effect. So I have seen improvement with soft tissue as well.
Yeah, same here also for the fibrosis with some patients, not everybody, but with pentoxifylline given 3 times a day, usually over a couple of months, some patients had some response, which was actually really impressive.
There's a question, Dr. Villa, specifically for you. Do you have any insight or experience with steroid injections to the salivary glands before or during radiation to help prevent xerostomia?
That's a good question. I've never heard of steroid injections in the salivary glands. There's a few trials. There's a trial that has just opened the phase 2 and multiple sites, including our sites, using gene therapy in patients that developed xerostomia following radiation therapy. The phase 1 data were published and they were very, very exciting. But I've never heard of steroid injections. No, I don't know if anybody else on the panels.
What's new to me? I haven't heard that, but sounds promising. Excited to see if somebody's successful with that. Do any of you use zinc in your practices for patients with xerostomia?
Not for xerostomia, but I recommend it in patients that develop taste changes. Zinc supplements, daily supplements. There is some literature on it, and it may help in some cases of dysgeusia, taste changes from radiation therapy.
Yeah. Awesome. There's a couple questions about will the chat and Q&A be available after? I believe yes to both or to all 3. Definitely the webinar will be posted on the site, and I believe that the Q&A and the chat may not be able to be saved, but I'm not certain about that. The Q&A should be able to be saved. Let's see here. Jamie, what's the most debilitating side effect that you have overcome, that you think that you weren't sort of, that surprised you, that might be helpful for some of our joiners to know, to maybe expect? Or
the most debilitating one is that it's just opening my mouth fully to even get food in. Mine's not great, and I still I used to go to physical therapy 3 times a week and have someone physically stretch my jaw out, but it was just not getting better. But doing the stretches every day in the morning and having a really strict routine, it has helped me throughout the day. And now I'm able to, like, I couldn't even put food on a fork to get in my mouth. I eat like a little squirrel and tear up food and place it in the back of my right side, because I think a lot of patients they'll probably say that they only can eat on one side. But I think getting over that hump of, there's a lot of, I was scared I was going to choke too. Like if I was eating, I got over that. So I'm able to eat more essentially. But that's just the thing. I have to be very regimented with my stretching routine in the morning in order to have a normal day.
Absolutely. I hope it only gets better over time. Being 7 years, there's one question about being even farther out than the typical kind of 5-year mark. What should, Dr. Villa, what should dental be looking out for even more than the typical kind of 5 years out? Is there anything specific or is it all the same?
Can you repeat the question? You were breaking up.
Yeah, sorry about that. If somebody's farther out than the typical 5 years, are there any changes in the recommendations that dentists should be looking for?
So I would say no, in the sense that some of these complications can also develop farther out past 5 years, unfortunately. And for example, if patients develop dry mouth, this can persist for longer than 5 years in some cases, which pose the patient at a higher risk of developing cavities. We also see some cases of Osteoradion necrosis that can develop after the 5-year mark. So my recommendation would be to continue see the dentist on a regular basis, at least twice a year.
And they should be looking for the same things that they've kind of always been looking for. Yeah, I think it's a lifelong thing. Kind of as we're winding towards the end here, are there any last minute tips or tricks from our panelists that would be able to share with our webinar participants? Let's start maybe with Dr. Toth.
There's a comment in the chat that I agree with. There's I'm sure there are several apps, but there's an app from Heather Starmer, a speech therapist at Stanford, called Head and Neck HNC Virtual Coach. That is, I recommend my patients download it now. You can get it in the App Store. I think it's particularly good. So that would be my parting thoughts would be to check out the HNC Virtual Coach app that another survivor mentioned in the webinar chat.
Awesome. Dr. Villa?
Yeah, so there's also another app that we developed with the International Society of Oral Oncology. It's called the Oncolab, Oncology Collaboration. There is a lot of information about oral complications from cancer therapy, not only for patients, but also for physicians and doctors that take care of patients with head and neck cancers. And then, as you all know, the Head and Neck Cancer Alliance has really, really good material online on the management and oral complications from cancer therapy that I encourage you to go and check. They are available online for free for everyone. So there's a lot of good information now out there.
Awesome. Thank you. Paulie?
Parting words. I would say there was a really good website posted in the chat as well. One of the HNC website links to help you find trials if you're interested in some of those survivorship trials, depending where you are in your recovery. That and then using the clinicaltrials.gov just to take a look and see what's happening in the world of research.
Awesome. Jamie? Final comments?
I know going through it, it's very painful and it just seems like, I get it. You're tired and you just want to eat normal, but just take all the suggestions, give all the questions to your doctors. Like, it doesn't matter. I used to go in with a notebook. I'm like, okay, this, and I would just rattle it off. Ask all the questions and be receptive and be open and try everything that they suggest, because something is going to work for you. It might be painful at first, but it just takes repetition and you have to stick with it. I know it's painful, but that is what's going to be the best for you.
Awesome. Again, I want to thank our panelists, Drs. McMillan, Topf, and Villa, and the Head and Neck Cancer Alliance Ambassador Jamie for serving on the panel and providing their insights. A special thanks to the Head and Neck Cancer Alliance and the American Head and Neck Society for their time in organizing and hosting this forum called the Open Forum Discussion on Oral Cancer and its Treatments and Side Effects webinar. I hope you all have a lovely evening and thank you for joining us.
Thank you.